All right, I'd rather know at this point. Oh, so it just started recording. I am
Yep.
gonna pause it. Focuses on the recovery practice of psychiatric rehabilitation. We've been doing this work for about 40, 45 years now, and we focus a lot on employment. That's one of the key areas that we look at. And so the Ask Me Anything series is a way to look at different pieces of employment for people with mental health challenges. And today I'm thrilled that we're going to be talking about the peer workforce because that addresses both employment for people with psychiatric challenges and bringing the message to other people that they can work as well. So it's sort of a double win-win when we talk about the peer workforce. One of the things that those of us who have worked in this field have struggled with for many years is how do we do good advocacy at the state level? Because if state level regs aren't in place to support a vibrant and thriving workforce, then it doesn't happen. So I'm thrilled that today we have as our guest, Noah Abdenour. Noah and I have known each other for many years, and he's currently the director of whatever you guys call the Department of Mental Health and Recovery. I just can't keep up with all the changing names. But in that role, Noah has been able to be very innovative in really bringing remarkably pro-peer workforce regulations into their Medicaid definitions and so forth. So I thought he would be a fabulous panelist for our Ask Me Anything. Just a reminder that Noah is not here to present. The Ask Me Anything series is the opportunity for you all to ask Noah questions that you brought with you, hopefully. And it can be anything in this general arena about Noah's work. I'll let him introduce and talk a little bit about his work first. But then we're going to absolutely invite you in to ask questions, and we hope that you will ask many and ask often. So with that, let me kindly turn this over to Mr. Noah.
Good morning, Lynn.
Good morning.
Yeah, so the words we use here for my position, I'm the director of peer support and recovery for Texas Health and Human Services Commission, HHSC. And do you think it'd be helpful to just do like a little background on?
Yeah, that'd be great.
Okay, so I think the way that I got into this work initially, I think a quick way of just kind of describing the creation of our area is to talk about my own path to getting to this job. I had, first and foremost, my qualifying lived experience went on for about a decade of my 20s. So I had like stuff not going well. Ultimately, I was on SSDI, got those messages from providers that like, I needed to not stress myself out with a full-time job. That probably wasn't something in my future. And to probably not live outside of an unsupervised setting, I really internalized those messages of not being able to, participate in the world. And for me, it was just out of desperation and kind of looming homelessness, things just really not going well. I had searched, I was like, where is the pill or the therapy that is going to fix me? And when I couldn't find, when there wasn't a pill that would fix it, I felt that I had failed myself. And so, a couple of hospitalizations and just like everything kind of crashing on top of me led me to this place where I had to start really digging deep. And I know Lynn taught me a long time ago about dissatisfaction as an avenue to change. And the life that I was living was no life at all. It was very mostly lonely and boring was the two things: chain smoking cigarettes and watching daytime television, and really seeing no path out of that, like led me to a place where I just didn't see things getting better. So, trying to make some decisions on how to remedy that involved a lot of substance use and just kind of cutting some corners didn't help out. And ended me up in hospitals. And it was my last hospitalization, where I was there for a pretty extended amount of time. That's where I was like, I'm at a point where I will try anything to move forward. And so that's where I started making proactive steps in my life. At first, I thought it was out of sheer terror, and just to keep a roof over my head. But then that led me to like just diligently working on myself, ultimately finding a support group, because I didn't want to be isolated. I'd gotten this label of the borderline personality label, which led me to DBT, dialectical behavioral therapy. And I didn't have any money. So it was like a new intern kind of person that was, I think she was in an idealistic place. I was working really hard on myself. And it just kind of lined up. I always describe my own recovery story as like, I was blindfolded in the dark, walking on a tightrope. And I think through a combination of, privilege and working hard and a lot of luck, like I was able to land my foot in the right spot, because they're in the beginning recovery, or whatever we call this, it can be so fragile. And so, ultimately I found a group. It was the first mutual aid support group that I found was a Depression Bipolar Support Alliance group, that met at a psych hospital where I'd been hospitalized. And that was the first time I found some people that were, started asking some questions. They're like, wait, how many medicines are you on? And then, just kind of, I was like, wait, this could be somebody else's fault. I was like, right, and so that was when I really started to move forward, was when I was able to change my doctor to a new person, and then went from like 15 medicines to less medicines, way less medicines, got like a re-baseline. But all of a sudden, like the world started to open up. I started to be able to have friends again. And, I think like started to see possibility and have like emotions. And I remember for a little bit being a bit in terror, because I was like, I was sure I was manic. I was like, I'm experiencing mania. And I'd go to my therapist and like, I'm sleeping X amount of hours, I'm eating, but like, I feel like this has got to be mania. And I remember her saying like, Noah, I think you might be happy. And it was just like, it'd been so long since anything positive had gone on that I didn't know how to experience a positive emotion without slapping a label on it, and so I pathologized myself. But so that was the path where I like kind of looked around. I had my $700 a month in SSDI money. But then it was like, being elated to have my life back only lasted so long. And then it was like, okay, well, what am I going to do? And so that's how I put in an application at a place where I'd been hospitalized. I got denied immediately as a former patient. And I had another application in at the state hospital in Austin. And so I downplayed. I was like, I know I put that whole essay about my lived experience, please disregard. And the volunteer coordinator there, she's this, old Southern drawl lady. She's like, sweetheart, we got a program just for folks like you. And it was, Austin State Hospital was running a pilot at that time, a peer support program that they were, getting going. So I went. I'd never heard of peer support. I'd never heard of the concept of recovery in mental health. I thought that was some addiction word or whatever, it was 12-step or AA. That's what recovery was. So I had this long conversation with the coordinator, Sarah Martinez, who I know Lynn worked with both of us a lot, and told her all the things I'd never want a prospective employer to know about my, the substance use history, the hospitalizations, the struggle, the isolation. But more than the negative part, I also was able to articulate that path forward. Like what were the things that helped me to be able to move past those very debilitating labels that I'd, gotten from others, but worst of all, put on myself, So when I started to learn about the history of what peer support was, I'm volunteering at this hospital. I'd never heard of this being a job. Like, first of all, it was like, if people think the state hospital, it's not the easiest place to work, but man, being somebody that only worked in restaurants, like predictable schedule, I have recourse if my boss yells at me, like, like it seemed like heaven, and so like I love the work. I loved the different people that I got to meet and the stories that I would hear. And I loved, like, I'm always somebody that's questioned authority and like kind of pushed back, and it always got me in trouble. And that was like my job as a peer specialist, was to not just take the system's word for it, to like really dig in deeper and to challenge status quo. And I just remember a position finally opened up. It was a really hard decision for me to make, whether to apply for that position or not. I had family members and providers that were like, you're going to put your benefits at risk. But it was one of those things. I remember late at night thinking, if I don't apply for this position, I'm going to regret it forever, So I went ahead and applied for that position. I thought for sure one of the other people was going to get it, and I ended up getting that position. So that was like my own like process of like growing as a person, just kind of in parallel with, like, this is very early on in the peer support, its evolution here in Texas. So I kind of came along when things were just getting going. We had a certification, kind of like it was something designated by the agency. We had some definitions of these practices, but it was still very early on in Texas. So over the next several years at the state hospital, I was able to move into a leadership position, began to get some amazing consultation from folks like Lynn. I think, moving into that supervisor position, understanding that being a supervisor was not being a peer specialist. Like, I had that background, but that's a different role. Understanding, I think one of the key things that I still talk about all the time and learned from Lynn was, the difference between performance and wellness. Those are very separate conversations, that we can be held as peer specialists to a high bar of excellence, high expectations professionally, and then in a separate conversation, support each other's wellness and have, inherently supportive work environments, but we don't have to treat peer specialists with kid gloves and, kind of just, what is it? Beware the bigotry of low expectations. And I've just seen peer specialists as supervisors, like, we hold each other to that bar, and that's really important. So, I got to a point where I then switched from working at the state hospital to becoming the director of a program in the community, Bluebonnet Trails, which covers 8 Central Texas counties, a public behavioral health provider. I was the director of their peer program. And right around that same time, I'm also going around the state. Lynn was also one of the first mentors who brought me along, I know, down to San Antonio. I got to see her presenting. She gave me little 3 minutes to talk, and like, I remember how nervous I was. But then started to go around and talk about how you build these peer support programs, what recovery-oriented care or person-centered care is. And we would kind of run into these barriers where, we talk about how to define lived experience, how to hire, how to supervise, what the service was. And we had a lot of folks out there that would, kind of be like, oh, that's really cute that you're coming out here. And we're going to just go along and do whatever we want, and we were seeing more people even starting to say, well, lived experience, maybe you don't have to have lived experience, so people started to define peer support and deliver the service kind of however they wanted. And
there was, we all have lived experience.
Oh, well, that's also
yeah.
true, right? I'm experiencing life right now. Yeah. And so that was really the big impetus. I know that, like, we still kind of look at Medicaid. It's a very imperfect thing. It's kind of, there's inherent conflict that exists around how medical and clinical it has to be. And peer support as a non-clinical service and other pieces. But the thing that we saw with the Medicaid piece was that we saw that as a vehicle to defining what is eligibility to get into this profession, what is the scope of practice, defining just different aspects that I think there was disagreement, and there were folks that felt they had the authority to define it over us. So there began to be like a policy effort, and there's a foundation here in Texas that I had been working with, the Hogg Foundation, that they had some policy positions through some consultation. They decided to fund peer policy fellowship. So we had peer specialists in these policy fellow positions that were able to dedicate time. And I think, there had been a bill in the past that was filed, but it did not pass. There was opposition from the Counseling Association. They saw us as a threat to kind of compete for business with them. So over the next, Texas meets every 2 years. So over the next 2 years, we really started to build a more formal consensus among the peer specialists on how to move forward. This is the mental health and substance use worlds. And then get broad support from like different advocacy groups. So the next session, this is in 2017, we really showed up united, organized. We had like, the agency here was on board with everything, and they were pushing internally, and we had, all these different foundations, and the Nurses Association, social work folks, the like NAMI, and like all the mental health players were lined up. And then I think most importantly, we showed up, the peer support folks showed up united as well. We were holding weekly calls because we feel passionately about stuff, right? So we created a venue to disagree about
right
stuff.
now, you were in the current role, right? So
No.
oh, okay, I'm sorry.
No. I was still in the community at this time. And so once we got that coalition was really important to getting the bill passed, because we would show up and not disagree with each other in public. We had a forum to disagree with each other. And I think that was a key to getting the bill passed. So once the bill passed, we had created a work group.
Can you describe the bill? Not in detail, but just let people know the bill you're speaking of.
Yeah, so the bill number was House Bill 1486 in the 85th legislative session for Texas. Chairman Ford Price was the author of that. So one of the strategies is we got a Republican a Republican legislator to be the sponsor, which in our state is very important. A co-sponsor in the Senate that was also a Republican, and the chair of the committee that it would go to. So we had it all lined up. But the bill was to create a Medicaid benefit or Medicaid peer services benefit. And then within that, it meant describing the scope of practice, the eligibility to become a peer specialist, the eligibility to receive the service, the supervision, the certification. So it was like to codify all these elements of what it meant to be eligible, then to become, and then to practice as a peer specialist. So that was the bill. And we would codify that into the state, they call it the Texas Administrative Code. So that's into the state plan. And that's like the law that governs all things health and human services.
Okay.
Yeah, so we assigned in the bill a work group that was comprised of peer specialists, trainers, organizations that employed, all sorts of folks to work with the agency to define all these pieces. I was fortunate enough to be selected as the chairperson of that committee, which, is very different than a different role than I had thought I'd be on the committee. And so I had this list of things I wanted to focus on. But as the chairperson, the role was to elicit feedback from the group to make sure that we were, considering every voice and moving forward in a diligent way. And so it's just a very different role than I had anticipated. But we had some very big wins in that. We were able to, one, make sure that peer support, you had to have lived experience. That was the number one thing that we had on our list. Number two was to define lived experience, not just as a diagnosis, but as we defined it. I don't know whose words this was, but it's a significant life disruption. That means, hospitalization, incarceration, homeless, like that you are living your life and then it was disrupted. And then more important than the disruption is you're able to articulate that path to where you are regaining control of your life and now living in a way that's not completely inhibited anymore, So we have that as the definition of lived experience. And then the other big win is we created what I call an experiential path to becoming a Medicaid supervisor. So that means a peer specialist in Texas, if they have 4 years with a certification, they're able to be credentialed as a supervisor under the Medicaid benefit, which that was something else. That was kind of like a bit pie in the sky, but we were able to get that.
Huge wins for the field.
Yeah.
And I don't know about for folks listening,
Yeah.
but I know in my experience in some other states, what NOAA and the peer community in Texas was able to create is really remarkable. The standards, the definitions, the ability to pass on to supervision, all of that is so exceptional. And so, Noah, let me pose a question to you from one of the people who sadly has to leave in a minute. So let me give you this. What are the most innovative things you are seeing in Texas as it relates to the peer workforce?
That's a great question. I think I mentioned that I think one of the things that we lack in this field is like moving into like leadership opportunities. I think one of the challenges that we have is so many of our grants and they fund direct services, but they're not, Lynn, I've heard you call it, they're not creating peer infrastructure. So
they give you dollar for dollar for your deliverable.
Yes.
Do 17 rap classes and priced out how much it'll cost you to do that. And that's what we'll pay you.
Yes. And I think
the money goes to the entity above who takes all the overhead. Like
often these funds reside inside of universities. It's often clinical folks who may have lived experience that are administering them. And so that's one of I think one of our biggest challenges is how do you cultivate people to have true career ladders and then move us peer specialists, not just people with lived experience, but peer specialists into more leadership, into different kinds of roles, moving into research or other kind of administrative type roles that have so much impact on this. And so, in Texas, I see a couple of things that we're doing. One is that Hogg Foundation, they have a policy fellowship. And so that had existed for several years on a professional, like an academic track where it was postgraduate students that would get into these fellowship positions that were funded inside of organizations that were doing mental health policy. And, my team at the state hospital was involved in trying to humanize some of the conversations that were being had. And then ultimately the Hogg Foundation saw so much value in having peer specialists in the room that they decided to double the size of the cohort from 4 to 8 individuals and to have 4 of the people be what they call peer policy fellows. And what that meant was they were full fellows in every single way. It was just that their path was a lived experience path into those roles. And so, they have, we're on our 4th cohort right now. And that's been a path for people to get into an agency like HHSC. We have several former policy and, both peer and academic fellows that work inside of the agency, but also moving more formally into like the legislative arena. And then, people going for grants and service delivery and starting their own organizations. So, I think that's one of the most innovative things we have going here.
I know, I love it. You guys are doing all the different pockets of leadership development and building that capacity. Because so often in peer-run agencies, people are attracted to go work there because of the peer support and the skills for peer support and the skills for management are exceptionally different. And
Yes.
so to learn some
The same with the business portion. Yeah, like we're passionate. We don't necessarily get into the work because we have MBAs,
Right, that's right.
Yeah.
So a related question here, how do people with lived experience fit in the state and federal government? And how can local people inform what is happening? And I assume by that, inform those of you in state federal government what's happening.
Yeah, well, I think first of all, like the first thing I learned moving into more of these policy areas is how accessible they really are in a literal sense, even though from a perceptively they seem and their access is it seems inaccessible. Like that you can like there's always a public hearing or there's public comment. There's formal ways for us as just citizens to have input into either public agencies or in like the legislative process itself, that you can walk into your legislator's office and it like the door's open. And I think some of these things it's very difficult to figure out what those processes are. So I think one of the first things would be to really go and understand where those access points are. It's almost like you need a Rosetta Stone kind of thing, like somebody to decode some of these paths. I think our skills as peer specialists make us uniquely qualified to build relationship with people. And so I think it's like trying to find people that are doing this, whatever kind of like, whether if it's local, like, who's going down to the city council meetings, using your kind of peer support, relationship building skills, really to have somebody else peer support you through some of these processes. Because that's honestly how I did it, was finding people that were doing it and became friends with them. And they guided me through, and I stumbled and bumped into walls and furniture. But
and I know now some of your organizations are doing things about how to understand the legislative process or how does government work, to demystify government processes so that people can feel more confident taking those steps. So,
and for me, I'm an experiential learner. Like I could read books or look at slides till I'm blue in the face. I'm not going to understand it until I walk around in the shoes.
Yeah,
so
absolutely.
That was for me, the best way was finding other people doing it. Find points of common interest or whatever, help them out a little bit, and just kind of like walk around and understand it that way.
Yeah. Let me go to another question for you. Hi, Noah. Thank you for sharing your story. I'm curious if the bill you mentioned was the first time peer support was considered a billable service under Medicaid. How long do you think the process took to incorporate peer support into Medicaid?
Okay, so that's a really good question. It depends on how you define it, right? Like, so technically, peer services, there was a letter from CMS, what is that, the Center for Medicaid Services. They sent out a guidance letter to states in 2007 that guided them that peer services, first of all, we were declared an evidence-based practice. So that was the first thing. Like we were declared by CMS, like that. There's nothing more official than that. I urge you all to point back to that if anybody ever asks about the evidence. We've been declared evidence-based practice, right? So first was that. Second was gave guidance to states and encouraged them to allow for billing under psychosocial rehabilitation.
So one thing before you go on, Noah, is that every state has to do its own process. So this is not a national thing. This is each state decides how to do it.
Federalism, right? Like the wonderful principle of federalism.
Right.
So like Texas had defined that peer specialists were eligible to bill under an existing provider and service type. So they could do skills training and psychosocial rehab. But there were some challenges around that where like it was relegated to certain, like a limited number of provider types could bill. So only our public behavioral health centers in Texas, that was the only place that peer specialists were able to bill. It was only for mental health. And what the conflict that would happen is if you read the rules very literally, you would end up with case management, not with peer support. Now, we receive guidance from experts nationally, like Lynn over here, on how to do documentation, how to deliver the service, and still be in alignment with peer ethics and values. It is possible, but it is a backbend. It isn't a natural thing. So that is like, we were technically able to bill, I think since about 2009 in Texas under those circumstances. We created a peer specific Medicaid benefit. So it was more in alignment with national standards and like, had, peer supervision. We require all the elements that we think will help us deliver a service that's more in alignment with what peer services should be. That's what we did with the second one. So the first bill around that was filed in 2015. The agency tried to do it on their own in 2016 and it failed. In 2017, it ended up going through. And I think it actually came up in a committee in 2012, but nobody knew what it was and they just moved on. So I think technically it happened over 6 years and then it didn't implement till 2019. So it went live 8 years later.
And so the first state that got Medicaid approvals that really opened the door was Georgia back in 1999. And so they were the first one that convinced Medicaid that peer support was the kind of workforce that needed to be invested in. Within Medicaid, there are two kinds of ways that states can get coverage. One is as a service. So you can get coverage for a peer support service within the larger behavioral health. The second that Texas got in their second bill was a provider coverage. And that's very different. Are they covering for peer support services for services done by a peer supporter, or are they done by peer support services in behavioral health? And that was the difference. Could somebody who is a certified peer specialist bill for services like many other professions can, or could only they be hired by another agency who offered a peer support service? So that gives you the difference of who's in control of what the position looks like and all of that. If it's just housed within behavioral health, it gets very washed down. It gets very co-opted, etc. Right? No, I'm sorry. I'm supposed to be quiet.
No, yeah. The context is very helpful. Yeah.
Yeah. All right, we've got another question up here that I skipped because it was a little different from where we were. So, Noah, what do you hope to accomplish in your role before you leave?
Oh goodness, this is something I think about a lot. So in I had two main jobs before. One was at the state hospital, and I spent 6 years there building a team, and like what we got to an amazing place there where we had, we were seen as equal with any other discipline inside of the state hospital. We had complete autonomy to operate. We had fun. It was an innovative group of people, but we had there was a change in leadership. A different superintendent came in. I started to lose some of my people because, people want to grow in their careers. You can only keep them so long. And when you had a new leader come in that they didn't think peer support wasn't important, but it wasn't one of their top. They were safety person, and peer support, sure, it was great, whatever, And so what I saw real quick, like over like not that much time, like maybe a year, like our team receded so much that the huge progress that we made, like it went away quickly. And then when I switched, and you know, I left it just without those two leaders, without a strong peer leader and a strong executive leader, the program just recedes real quick. And I took over for a very strong community-based peer leader, Bill Gilstrap, who he had transitioned out of the position. And what we saw in about a year there was the same type of thing. When they put the peers specialists started reporting to the center directors, to clinical, that whole program receded. And so that's something I've thought a lot, like how I think the number one goal that I have is how do I build something with roots, to really have roots in it, so that these, the program that I'm overseeing now, it's entrenched in a way that they can't yank it out, So that's something I work on, is how do we entrench into the agency, but the other is how do we build these services statewide, so that the peer profession is growing in a way that is autonomous from these other elements that can impact it. And so that's really where we're seeing that the big answer to the question is to invest in peer-run, community-based organizations, and to put more statutory and contractual options for our clinical providers, to partner with, to contract with. And it's going to take us, we move in 5-year contract cycles here. It's going to take us some time. I see it probably about 7 more years to really trying to get these things entrenched. We want to bring in more resources that are not helping these experts in the field to deliver peer services, because we already know that, like give us resources on how to write grants, how to track multiple employees across different contracts, or succession planning. And so, that's really elements we're looking to, is how do we seed and support more peer organizations, and then empower them to be funded in diverse ways, and then, try to encourage or kind of force our providers to work with them more and more. So, that my big thing is to really hope that we can, one, see that shift, and the other is that the litmus of control in our field is outside of the state, and it's outside of these like kind of entities and organizations that have been our allies. I think we're at a place where the peer support workforce in field can have self-determination. I think that's the other thing that I'm trying to move away elements where the state is in control, to try to let our field step up and take.
Yeah, it's so interesting in any sort of social movement. You go through those early stages where your allies are so important and so needed, but then it gets hard for the allies to be able to step back and not keep that place, right? It's like, okay, let the children fly now, get the hell out of their lives. That transition place can be really challenging. I think this one will be the best one. Here you go. What are the greatest needs of the peer workforce right now?
It's asking me what are the greatest needs. Okay, I thought it was like one of the. This is a great.
Great question.
Yes, it is. That's a difficult question.
Yeah.
I think
just say this up before you start. Is that when we're asking questions like this, we have to remember that the peer workforce also is different state by state. There is no connection nationally. So what the peer workforce in South Carolina or North Carolina might need versus Texas versus Massachusetts can be very different. But I know, Noah, you work a lot at national as well. So,
well, one thing I'm seeing, I see a duality here. There's two, and this is more big picture than, I think on the ground, we need better paying jobs, and we need more livable wage, and we need to be respected as that needs to continue, that we're respected as a true discipline. So getting into the bigger picture though, I see the kind of two main things. One is you've got a lot of different definitions of what this workforce and service is right now going on. And you've got Medicare's trying to define it however they want. You've got like the Department of Labor defining it however they want. You've got the workforce commissions doing whatever they, and these are not happening in concert with one another. And we're absent, like Lynn was saying, of that. I think we have some advocates that work inside of other organizations, and now we're seeing more peers. I saw Amy Brinkley. She's one of our peer support leaders inside of NASHPID, the National State Health Program.
State Mental Health Program Director.
Thank you. That one's it. That one's a mouthful. But what we do, like that, they're going to come through the lens of our state, like the state commissioners over, like that's a trade association for the state mental health commissioners. So they're going to look through the state public health lens. We've got places like NADAC or Mental Health America, you know, I think, but and they're hiring more peer specialists. So the National Council on Mental Wellbeing is they also, but all those people are coming through the lens of their own entities. We don't have somebody that's purely advocating through the lens of peer support in our workforce. I know the National Association of Peer Supporters is getting closer to being much more involved. You know, hopefully we'll see that continue to grow. But I think that's one of the concerns I have right now is the amount of interest at a federal level in promoting these things. We saw it in the president's State of the Union last year was mentioned. SAMHSA's created the Substance Abuse and Mental Health Services Association or something like that. They've created an Office of Recovery. So we're seeing a lot of this be recognized. We don't always see peer specialists at the table helping to design these things. So I think that's one of the big opportunities and concerns is that the other side of that is kind of a split in our field, I think, between folks coming from more of an advocacy perspective, which is I think it's an important voice. And I think typically that's where we've seen the lived experience advocacy, but that's a little bit different than a peer support workforce perspective, which it's just sometimes those two things are a bit different. And I'm seeing that kind of get pushed together. So that's kind of another piece is that one, we get more self-defined and self-advocate. I think that's a big opportunity right now. And the other is like whether we can start to make a bit of a distinction between just broad lived experience and then people working in the workforce.
Yeah, and what I've been saying is that peer support currently is like a foster child.
Mm-hmm.
And everybody's arguing and putting dibs in to adopt.
Yeah.
And if the peer community doesn't have the legs to do that adoption, we're going to lose peer support.
Yeah.
Because there's a lot of people out there right now that want to be the adoptive parents, and right, and we run a risk of losing it with all of that going on. So yeah, absolutely.
Yeah, and Lynn, off that, I think the one other thing is people want to create the peer everything, the peer caseworker, the peer workforce person, the peer intake, the peer service coordinator. Like I think people see value in lived experience and they want to put peers in all these different roles. And I think it's not honoring that peer support is its own thing. And so that's really from our perspective, we're trying to be like, okay, we can create paths for peer specialists to get into case management or get into, workforce support positions. But when they're in those positions, they're a case manager or they're a care coordinator, and that's fine, but they're not a peer specialist. And I think making that distinction to not do peer everything, but we can't create opportunities for peer specialists that are credentialed to get us into these roles. but to split them as separate, I think that's another
And
thing.
that's because the word peer has become co-opted. The
It's,
word
yes,
peer is the current version of patient, which
yes,
was then consumer, and now it's peer.
yeah,
Anybody with lived experience is a peer, when the reality is peer is a relationship. So nobody can be a peer in the first place. Right? And it's a
totally makes sense.
relationship between two or more people where there is that common connection and there is mutuality. They are equal. No one has power over each other. So when people go, oh, my supervisor's a peer, I go, oh, they can't discipline or hire or fire. Oh, no, they can. Then they're not peer. There's no mutuality there. Right.
Yeah,
And so I've been really advocating that people do peer worker, that we do not allow those to be separated, because that's the title of the role, peer support specialist or a peer worker. It's not peer by itself. It's that role that we are trying to preserve, define, and do all of that. Everybody else is not a peer. They're whoever they are with lived experience, but they're probably not a peer, right? So anyway, it's a little bit of my soapbox these days, but I think if we can get the word peer back to its original meaning and not just use it as a new label, oh, they're all peers. Yeah,
right. Yeah, and peer means mutuality. Yeah, like,
and relationship. Yeah,
yeah, yeah,
right. And one other thing I would say to be a workforce needs, and this is part of the defining, is the struggle between different systems that are close, like addictions and mental health, and for a bunch of reasons that are for efficiency's sake and for billing's sake, are being put together in ways that are not helpful and only confuse the service more. And so
yes,
finding ways to make sure that, you know, they can all be under Medicaid, but let's not say that we're all the same, because the systems that we work in and the systems
yes,
that people get treatment in are very different, with different cultures and different things that people come out of the systems with, that
yeah.
often they have to recover from, but they're different. Yeah.
Yeah, and I want to brag a little bit about Texas. I think one of the we were able to try to thread that needle.
Yep.
The way our certification works is first, you have to go through a self-assessment, make sure that you meet eligibility and all that. But anyone, whether you're family peer support, mental health peer support, substance use peer support, or our other one that we're recognizing is justice involved, we
Right.
go through what's called a core training first. So that's like, what are the universal values, like having a point of mutuality, using your story to support, but to not coerce someone, this that we all come from different views of the world, and the way that impacts a relationship, basic list. There's the universal things. Then you break into what we call your specialization, which matches. We got mental health, we got substance use, we have the family, and we have justice involved. And like Lynn's saying, those are different cultures, there's different words. And I like to talk about, like, as peer specialists, we fill the cracks that exist in the system, and they're different cracks, and so the role of a peer specialist in a substance use system is going to look very different than in a mental health system. Just inherently, the challenges are different. What the pain points are different, and sometimes they can be perceived as being at odds. But I think if you understand, and this was something Lynn taught me also, understanding the systems and where the deficits are, that's really where the peer specialists have positioned themselves, is to
So
alleviate.
on the big picture,
Yeah.
we're all doing peer support. We're all sharing our lived experience to inspire hope. Let
Yes.
people know how we work through all these cracks. How did we navigate the system? But in my experiences in the mental health system only, it's really hard for me to share my experience in a way that is useful to someone who is in the substance use system. And I love the way you put it, because the cracks are different.
Yeah.
So we use the same tools, but they look different because they're also system related. So, and I love exactly, it's another thing you guys did brilliantly, is thread this needle where all the systems can have good peer support, but we're not calling them the same thing for the sake of billing and diluting everybody so that no one's doing the good work. Great stuff. Let me see. I think there was one more question in this, and this will wrap us up. How can other providers and healthcare professions help to support and advocate for peer specialists?
All right, Natalie's bringing the heat here.
Yeah, good.
So, I think there's two main things that I think other professions have done. I think back to myself. The first thing is, it's something we talk about in peer support. It's like advocating with, not advocating for, doing with, not doing for. So I think something is, if a peer specialist is able to be present and you can bring them, and I think it's helping us have access to tables to speak for ourselves, as much as possible. I know sometimes some of these conversations can happen where you don't have accessibility, but I think that's the first thing a provider can do. Another thing is to just understand, like, take a look at the code of ethics, understand what the work is. And I think some people just assume it's like, I get peer support. It just means you've got lived experience, right on. And I think not understanding the nuance and the number of competencies and like, this is hard work that takes, high levels. I know Lynn always, I think one of your sayings is, I'm an expert at not being an expert, and that takes expertise.
Expertise.
Yeah, I think to when I first left my very first training, and I'm sitting there with every person I was working with, thinking about, okay, where do I get my story in? Where can I have impact? I want to change this person's life. And as I got better at doing peer support, I realized, like, that isn't peer support. Like, I have to be present with this person. I have to, like, be both empathetic, but like be careful about my own beliefs and my own stuff. And like, like the nuance to being in relationship with another human being, there's a lot to it. And the fact that you're always walking upstream in so many of the settings that we work in and are misunderstood. And
very often peer supporters are working on two levels. They're using that lived experience to inspire hope for both people coming to services and for service providers who are often as hopeless about recovery as people using services. So everything that a peer support worker does to help people using services, they're often doing it with little modification to help service providers see their role differently, see recovery differently, see the people that they're working with differently. And that leaves you in a very lonely middle land where you're working by yourself this way and that way.
Yeah.
Very little supporting you in your work.
Yeah.
So I think another thing that people really help is just myth bust.
Yeah.
When you hear these myths about, oh, they just sit around and talk. No, actually, they're trained to be very specific about how they're using their lived experience and why they're doing it. They're actually trying to reach the same goals you are, and their work can actually complement your work, right? And things like that to myth bust when you hear just things that are inaccurate.
Yeah.
Yeah. Oh, I love these topics. I could just do this all day long. Anybody else have any questions? All right. Well, I want to say thank you, everyone, for coming. Thank you, Noah, for sharing your time. Thank you, Hazel. You were also good. Thank you, Georgie and Izzy. You were also awful good. Hi, Hazel.
Yeah.
I should log off.
I'm going to get a walk in a second here.
Yes. As you log off, there'll be a survey. We do ask you take the time to fill it out for us because I have to report to NIDLR And if I have no survey results, neither will get mad at me. So just do it for me if you would. I appreciate it. I hope you all have a great day, a great weekend. Happy Mother's Day to any of you who that's applicable to. And you can define that however you want. On my friends, I say you're a mother. Happy Mother's Day. So enjoy, everybody. Thank you so much. Noah, we'll talk soon. Great to see your face and spend this time with you.
Awesome. Thank you so much.
Bye-bye.
Bye.